We're going to start out our discussion of male reproductive concerns with a question. Which assessment finding in a 65-year-old male would be most suggestive of a problem with the prostate gland? Choice 1, PSA level of 3.5 nanograms per milliliter. 2, the client states, I have to get up several times at night to go to the bathroom. 3, the urine is blood tinged. Or 4, the client states, sometimes I have trouble maintaining an erection. So we're looking at a prostate problem, and the answer is number 2. Now, I have to get up several times at night to go to the bathroom is typical of prostate problems. Now, one answer told us that the PSA was 3.5. That's perfectly normal. The PSA should be less than 4 nanograms per milliliter. Now, if we talk about benign prostatic hypertrophy, I want to review just a little bit of physiology for us. So I want us to look at one picture here. I want you to look at this first picture here. And this blue thing in here is the prostate gland. And note that it surrounds the urethra right where it leaves the bladder. So it surrounds the urethra, and as men get older, usually starting around the age of 50-ish, that prostate begins to enlarge. And as it does, it pinches the urethra. And so it makes it harder to start the urinary stream. There is difficulty starting the urinary stream and difficulty emptying the bladder. So those are major symptoms of prostate problems. We can manage this. Many times these patients are given a drug called Hitrin, which is terazosin. We mentioned that when we talked about alpha blockers. And what this does is it doesn't shrink the prostate gland, but it makes it easier to open the sphincter. And a major side effect of that drug is hypotension. In fact, it's given as an antihypertensive, so we have to teach patients to get up slowly and all the teaching that you would do when a patient is receiving an antihypertensive. Another drug that's commonly prescribed for benign prostatic hypertrophy is Proscar. Proscar is a drug that helps to shrink the prostate gland. Now, Proscar, new research on this suggests that there may be some preventive effect with Proscar in relationship to prostate surgery. More studies are being done, but the evidence suggests that people that take Proscar have fewer cases of prostate cancer. However, when they get prostate cancer, it seems to be more aggressive and more serious. So it's not yet routinely being used as a prevention for prostate cancer, but it may be as time goes along. Now I want to talk a little bit about prostatectomies. If a patient has benign prostatic hypertrophy, they're likely to have a TURP, this transurethral prostatectomy, this one right up here done. And this TURP, or transurethral prostatectomy, they put a resectoscope down the urethra and go in and scrape off the extra part of that prostate gland that was growing. They don't remove the entire gland, they just scrape off the extra part of the prostate gland. Now, in the immediate post-operative period, this patient's going to have really bloody urine, and it will get less so as the days go by. But in the beginning, they're going to have a lot of bloody urine. Bright red urine is normal. Clots are abnormal. So you would report clots, but bright red urine is perfectly normal in these patients. Then when the catheter is removed in a few days, they're likely to dribble because they've lost their bladder tone and the sphincter control. But within a few days after that, they should be able to regain their bladder control, so that any dribbling should only be temporary in nature, not permanent. Now, before we talk about other prostate surgeries, I do want to talk a little bit about how we determine whether the patient has BPH or cancer of the prostate. When a patient has an elevated PSA, prostate-specific antigen level, all that tells us is the prostate is enlarged. Now clearly, if it suddenly and sharply rose, we would be very concerned that it could be cancer. But an elevated PSA simply says the prostate is enlarged. It does not tell you whether it is cancer or BPH. They'll need to do a biopsy. And the biopsy goes through the rectum. So those needles that are going to biopsy it go through the rectum. Now that means that this is dirty because the rectum is never clean. So the patient will need some antibiotics after a prostate biopsy. You need to tell the patient also that their ejaculate will contain blood for some time afterwards so that they know that that's normal and they're not going to be frightened by that. Now let's assume that this poor man has prostate cancer. There are some alternatives in terms of managing prostate cancer. Some patients will have surgery. Some patients will go for hormonal treatment and radiation. Now, as we'll see in a moment, one of the disadvantages to surgery is it frequently causes impotence. When you use hormonal treatment and radiation, the impotence is usually temporary. So they're given hormones to shut down the prostate. They may be given some local radiation to shrink that prostate, and they do that without having to do surgery. So that's one option to prostate cancer. Another option is prostatectomy. And if we take a look at some of the types of prostatectomies out there, the suprapubic, here's the abdomen, and this is the pubic bone. And the incision is in the abdomen. And note that the surgeon's hand on this picture is actually in the bladder. So with a suprapubic prostatectomy, they go through the bladder and to get to the prostate gland. Afterwards, this patient has a suprapubic drainage tube. So they have a tube going from the bladder out through the abdomen, draining bloody urine. And they also have an indwelling urinary catheter that will be draining bloody urine as well. It's possible to do a retropubic prostatectomy, in which case this, again, it's an abdominal incision, but they don't go through the bladder. So they only have one tube draining bloody urine, and that's the indwelling urinary catheter. And a perineal prostatectomy is very popular. With the perineal prostatectomy, the incision is in the perineum. Now, one of the biggie problems with a perineal prostatectomy is that nerves and blood vessels are frequently cut, and this causes impotence. So that's a serious problem. Suprapubics and retropubics may also cause impotence, and that means difficulty with erections. Now, if you look back at the picture of the perineal prostatectomy, I just wanted to point out for you here how close the rectum is to the surgery so you could understand why they're going to be on a low residue diet after surgery. And frequently they are. Until we get some healing here, we don't want a lot of things passing through there. All right, so now we talk about patients with prostatectomies. We said one of the problems with prostatectomies for prostate cancer is impotence. And so that's why many of the people will go and use the hormonal and radiation therapy. Of course, this is a decision that's made between the patient and his physician. Now, patients who have had prostate surgery may have continuous bladder irrigation, particularly those suprapubic prostatectomies. Now, in this, we have a three-way Foley and a GU irrigant. It's usually something like normal saline. And this goes in, flows, bathes the bladder, and then goes out and collects in the collection bag. The purpose of this saline bathing the bladder is to prevent clots from forming. So now on your shift, your patient had 1,000 milliliters of GU Aerogin instilled. When you emptied that drainage bag, there was 1,700 milliliters. How much was the urine output? Of course, 700 milliliters. Now don't forget that they can give you questions on the test where you have to subtract the irrigating solution to find the total volume of urine or other fluid that was put out. Let's do another question. A 35-year-old man asks about a vasectomy. In discussing a vasectomy with him, which information is most important for the nurse to provide? Number 1, a vasectomy involves tubal ligation done by surgery. Number 2, this is a permanent method of contraception. 3, the surgery takes approximately 1 hour. Or 4, a vasectomy may cause intermittent impotence. And the correct answer is number 2. When patients are considering a vasectomy, we need to let them know this is to be considered a permanent method. By the way, it doesn't take an hour. It's 10 minutes, snip, snip. It's a very short procedure. But let's talk about this being a permanent method of contraception. Some of you are probably saying, you know somebody that got it reversed. So do I. But it's not ever entered into with that understanding. Many times it cannot be successfully reversed. Even if they're technically able to connect it, reconnect the vas deferens, if they've had the vasectomy for any length of time at all, the body may actually be making antibodies against sperm because they continue to produce sperm and it's reabsorbed by the body. So the body may make antibodies against it. So there's no guarantee of fertility, even if they're able to reconnect the vas deferens. So when a person has a vasectomy, they need to be quite sure that they are finished having children. No matter what circumstances may happen in their life, they are done having children. So we teach the patient first and foremost, this is permanent. The patient who has had a vasectomy is going to need a scrotal support. Anytime there is surgery anywhere near a man's reproductive system, they're going to have scrotal edema. Sometimes the scrotum can be a couple of times its normal size, so scrotal support. And you must also teach them that they are not immediately sterile. This is very, very important. You don't want them to go home and do their thing with their wife and have one last child for the road, and this person says, not my kid, because they are not immediately sterile. And let me show you how that happens. If you take a look at this picture, down here is your testicle, and that's where the sperm are made, in the testicle. And here's the vas deferens. So we're going to cut the vas deferens here, and so cut it, cauterize it. Now, what normally happens before you get the vasectomy, you make sperm down here, travels up the vas deferens, back into the abdominal cavity, back here behind the bladder. Fluid is picked up in the seminal vesicle, some more fluid in the prostate, and it eventually goes out as ejaculate. Now that is a long trip. That's a very long pipeline. And there are sperm in the pipeline. So if you cut the pipeline down here, no more sperm are getting in, but there's a lot already in the pipeline. So many surgeons will tell the patient, don't even consider testing until you've had at least 15 ejaculations. And then we want 2 specimens negative for sperm a month apart. And when that happens, now you're sterile. So it's very important that we teach the patient that they're not immediately sterile. If they don't want to run the risk of increasing the size of their family, their partner should be using some method of contraception.